pathologist, Dr. Anila Abraham, Madam. We welcome you, Madam. Madam is Director and Consultant Pathologist at RENOPATH, Center for Renal and Urological Pathology, Chennai. She has done more than 80, that is 89 publications in national and international journals and 2 textbook chapters for her credit. We are eager to hear you, Madam. Over to you.
Thank you so much for the warm introduction, and we could start the session. A very good evening, and I sincerely thank the organizers of the ISO team, especially Dr. Radhika, for inviting me for this talk. And I've been specifically given the topic of post-renal transplant viral infections, and to discuss these 4 viruses, that is a Polyoma, Cytomegalovirus, Herpes, and Adenovirus. So why are viral infections really important to the kidney? Because you need to know that among the most common opportunistic infections, it is likely to be a viral infection after a transplant. And the risk for a viral infection, it depends on what is the type of virus that is encountered, what is the intensity of the immunosuppression that the patient is having to prevent his graft from getting rejected, and a number of other host factors which can again decide on who are the patients that are likely to get viral infections, starting from the age of the patient to the comorbid conditions, the presence of any injury, presence of previous rejection. The list is long. So the multiple factors decide on who could possibly be getting a viral infection following a transplant. And then also, these viral infections can either be symptomatic, which the patient produces symptoms, or it can be completely asymptomatic. And also, these viral infections can have direct effects, that is, the actual organ is involved, like in a nephritis or a CMV gastritis or an esophagitis. Or sometimes these viral infections can produce certain indirect effects. Basically, these viruses can cause a release of cytokines and growth factors, which in turn will affect on the immunity of the system, predisposing them to other opportunistic infections, and of course, the possibility of oncogenesis. So for these reasons, it's very important that we know a bit about these viral infections in the allograft kidney. Also, another factor that determines the chances of developing the virus is the type of immunosuppressive drug that is used. Those that specifically lower or suppress the T cells are known to produce or have a more chance of producing viral infections as compared to those drugs which attack or are targeted on the innate immunity, where then in those cases it's usually the more common to have a bacterial infection. So this is a chart which is very often quoted. That is a timeline or the timetable of infections. And I've just selected among only the viruses. You can have all the other types of infections also. And you should realize the first 1 year, it is immediately after the initial period of 1 week or 4 weeks, 1 month to 1 year, that is a period of maximum immunosuppression. That is when you have the maximum chance of developing a viral infection. Though it continues more than even after 1 year, the chances are still there. However, this first 1 year is the time when there is a maximum chance of a viral infection. So without further delay, let's move on. I have 4 cases to discuss. The first case is a 33-year-old male whose native kidney disease we really don't know because a biopsy was not done. It's assumed it was a chronic interstitial nephritis. His father was a donor, and he was doing very well with a stable graft function. But at 9 months, he had a sudden jump in creatinine from 1.4 to 2.1 over a period of 1 month. And a biopsy was immediately done. So this is an adequate biopsy. There was sufficient number of glomeruli. There was a blood vessel. And what is seen on this power on an H&E stain is the glomeruli essentially look normal. We'll go to a closer view later. But the interstitium definitely shows a lot of interstitial inflammation, a lot of inflammatory cells. There is not much of interstitial fibrosis. You can't comment much on this H&E stain, but probably there was around 10 to 15% was the maximum interstitial fibrosis. But predominantly 40 to 50% of the cortex showed this acute inflammatory cells. Going closer, let's look at a glomerulus. So we look for whether there is glomerulitis. It was not there. There were no fibrin thrombi within the loops. But what was catching our eye here is one of the parietal epithelial cells is much larger than all the others. And a closer view has a very suspicious intranuclear inclusion. Right, that is on the parietal epithelium. The surrounding shows a dense inflammatory infiltrate. And now looking at the tubules, the same intranuclear inclusion that you saw on the parietal cell is also seen within the tubular epithelial cells. Note the inflammation in the surrounding. Even on an H&E stain, you can see that there are lymphocytes that are infiltrating the tubules. So there is tubulitis, there is tubular injury. In addition, there are these intranuclear inclusions. So the moment we see these intranuclear inclusions, we have to decide what are these viruses or what are these factors causing. And the first thing we do is an SV40 immunohistochemical stain here, which shows multiple tubules of having these positive stain cells, that is the nuclei of the tubular epithelial cells. Around 30 to 40% of this biopsy, the tubules had positive cells. So the diagnosis is easy. It's an SV40 positive. We all know that's a marker for BK polyomavirus. And however, now with the BANF, we need to just score the virus also. So it's just not enough to make a diagnosis. And the scoring, I'm sure you all know, is consists of two parts. Like you have to get the viral load and you have to assess the interstitial fibrosis. And combining these two, you get the class or the BANF class of polyomavirus nephritis. So to get the viral load, you have to do an immunohistochemistry stain because that is much more sensitive. Though light microscopically, you may not see any nuclear changes, IHC can pick up those changes. So with the IHC, we score what percent. This percentage is number of tubules which have a positive cell. So among all the tubules in the biopsy, what percentage of tubules have positive cells? Based on them, we grade into less than 1, 1 to 10 or more than 10. And also we look at the interstitial fiber. The CI score is what we normally do for our interstitial fibrosis tubular IFTA scoring. So the CI 0, 1, 2, 3. So we have two scores. Then we combine, like if you have a low PVL with hardly any interstitial fibrosis, it's a class 1. Whereas if you have a very high viral load and you have a lot of interstitial fibrosis of 2 or 3, more than 50 or 25 to above, then it's a class 3. And anything in between is a class 2. So for our biopsy, it fitted into a BANF class 2 and a diagnosis of polyomavirus nephritis was given. So this is a virus I'm sure all the nephrologists would definitely have come across in their practice because among all the viruses, this is the most common one. And it's not just allografts. You need to remember there are case reports of BK virus nephropathy among native kidneys, especially in immunocompromised patients also. And the infectious agent is a human papillomavirus. And there are two viruses in that. BK virus, which you're all familiar and which accounts to 85 to 95% of our infections. Polyomavirus infection in the graft is because of the BK virus. A very small percentage, very rarely could be due to another virus of the same family, that is the JC or the John Cunningham virus. We'll go a little bit into that later. And how does the pathogenesis? It's a reactivation that we saw in the first chart during the initial 1 year. There is reactivation of the latent virus. And also, if there's any injury that is just ATI due to any cause, that can promote viral replication. Any episode of rejection, so that also, so it's like multifactorial as to what causes a virus to move from its latent phase to become active and cause the disease. So this is about a little bit of the virus. It was first described in a transplant patient who developed a urethral stricture. And this is the structure of the virus, which is a DNA virus here. More than 90% of the general population have a seroprevalence here. And It's usually transmitted via the respiratory or the GIT tract, and this is important. It lies latent in the genitourinary tract of the individual. So what is important for us to know, and this session, that the take-home messages on BK virus is, you need to look at the appearance of the nucleus, the nuclear inclusions, which are a telltale sign, which is very characteristically what we call as the ground glass appearance, or could be very homogeneous intranuclear inclusion. And that's usually in the tubular epithelial cell. Rarely you can see it in the parietal epithelium, which we know parietal epithelium is a continuation of the proximal tubule, right? So our case, I showed you the first picture where it was there in the parietal cell. You need to remember that on light microscopy, these inclusions may not be evident. They may look very normal, but if you do an SV40, some of those cells turn out to be positive, and even one positive cell is enough to make a diagnosis of polyomavirus nephropathy. So light microscopy, yes, but just because light microscopy looks normal, that does not rule out. We have to do IHC. And also, this virus is known to have caused a lot of interstitial inflammation, tubular injury, tubulitis, and interstitial fibrosis. All this can look exactly like acute cell-mediated or a chronic rejection, cell-mediated rejection. And they both can coexist, and differentiating them can be very difficult. So this is another point that you have to keep in mind. The next point that is very important for polyomavirus is when you have the inflammation predominantly in the medulla. See, now medulla is something we really don't give a lot of importance to on the graph. We are all concentrating on the cortex, from the adequacy, 10 glomeruli, 2 arteries. We are looking at the interstitial inflammation. We're scoring the IFTA. You're looking at the glomerulus. So medulla tends to be ignored. But if that happens, or if the medullary tissue is not included in the biopsy, there's a chance of missing the lesion of BK virus. So it's very important that a deep biopsy, which includes the medulla, is also there, because a 2 times higher chance of picking up if the medulla is there. And if you have a lot of inflammation in the medulla, give it a lot of importance and definitely do an immunohistochemical stain. Another clue that can suggest is when either C4D, or if you're doing immunofluorescence, they have a granular appearance on the tubular epithelial cells. Now, this is not peritubular capillaries. Peritubular capillaries are here. They have not taken up any stain. If you can look carefully, you can see those blackish holes. Those are the peritubular capillaries. These are the tubules with the tubular basement membrane, and a very granular staining along the tubular basement membrane can suggest that there is a BK virus. The reason why this happens is really not known, and you have to get an immunohistochemistry done when you see all these different intranuclear inclusions, starting from cell enlargement to hyperchromasia to variation in the size of the cell. You may not have an inclusion, you may just have granularity. And again, there is a lot of variation in the type of nuclear changes. So light microscopic definitely gives a clue, but the diagnosis has to be made by doing an immunohistochemical stain on it. So for immunohistochemistry, what do we do? It is the SV40 large T cell antigen that we're doing. This is something you need to remember. This antigen cross-reacts, is positive for all the 3 viruses. So when we, like this particular case, we are just assuming it is BK virus. It could very well have been a JC virus, because the immunohistochemistry cannot differentiate them. And if you actually want to know whether it is BKV or JC virus, then you have to do a DNA in situ hybridization specific with a probe for one of these viruses to actually identify the virus. So that is something we need to remember. And coming to the urine in BK virus, we all know about decoy cells. They're called decoy cells because they resemble malignant cells, because they are very large. There's nuclear enlargement, increased nucleocytoplasmic ratio. However, these cells also stain with SV40, and that's how the diagnosis is made. Another very, very characteristic finding of BK virus is the Hoffen. Hoffens are basically virally infected tubular epithelial cells that have shed and that have formed a cast with the Tam-Hosphol protein. So basically, it is a cellular cast, and these cells are made up of virally infected cells. Now, these cells, this scars can pass out in the urine, and this is again used as a non-invasive diagnostic finding in a feature in a BK polyomavirus nephropathy. We really don't do an EM routinely to identify it. IHC immunohistochemistry is a gold standard. But if you do an EM, this is what their intranuclear inclusions. And again, EM cannot differentiate these viruses. All of them look identical. Even the morphology of BK virus resembles adeno and parvo, and you have to actually measure the viral capsid diameter to differentiate it. So it's a cumbersome process, and so EM is not routinely done to identify or diagnose these viruses. Now, this is the latest, very recently come out guidelines for management of virus, BK polyomavirus nephropathy. I'm not going into the management part. This was only highlighted to say how important the biopsy and a histopathological diagnosis is for the management of polyomavirus nephropathy in transplant. It is the gold standard. Now, I had touched upon this earlier. I showed you the picture of a biopsy where there was a lot of interstitial inflammation. And also there was tubulitis. Now, the question is what the clinician wants to know. We all know it's a tightrope you're working on, whether to lower the immunosuppression because you have a BK virus. The only treatment is to lower the immunosuppression. But what if there is a concurrent cell-mediated rejection? What would you do? And the first question that the pathologist faces is there a rejection? Can you say for sure that there is no rejection? Now, the answer is there is no reliable diagnostic or morphological or immunohistochemical or molecular features to differentiate a tubulitis because of a cell-mediated rejection versus that due to a viral or a BK virus. There are certain clues that can give you a very calculated guess. That is, if your BK viruses are mostly in the medulla and you have inflammation and tubulitis in the cortex, it's likely that there is a coexisting rejection. Whereas if it's all mingled up together, it is in like in our particular case, the same tubule with the viral particles and lymphocytic tubulitis, there is no way that we can say that the tubulitis is because of the virus and not because of rejection. However, if you have vasculitis, that is diagnostic of rejection because the BK virus does not involve the blood vessels. The endothelium is not injured or it is not infected. So if you have vasculitis or if there's microvascular inflammation, like if there's glomerulitis or there's C4D deposition or positivity, all this antibody-mediated rejection can be easily differentiated. It is only the early cell-mediated rejection band 1A, 1B that you cannot rely on. The moment there is vasculitis, it becomes a 2A, and then you know that that can be called so. But the early rejection is impossible to accurately differentiate it. Now, JC virus, we need to know about it. Just like BKV, a very small percentage can be because of JC virus. It is known to cause a multifocal leukoencephalopathy of the CNS. Very, very rarely it can cause a nephropathy in the transplant recipient. There are just a few case reports. And this is very interesting. Morphologically, on light microscopy, they look identical with a lot of inflammation. Can cause fibrosis, tubulitis, inclusion. SV40 is positive. Now, how do you differentiate it? So when do you suspect a JC virus? You have SV40 positive with the inclusions. On the biopsy, it is a BK virus. But when you do a BK virus study in the blood, there is no viremia, nor is there viruria. BK virus. So in those conditions, when you have a positive BK on the biopsy, but negative in the blood and the urine, then you suspect whether it could be a JC virus. So this is another case where very few case reports which showed a JC virus in the infected individual. The only other way on the tissue is if you want to make an accurate diagnosis, you can do an in situ hybridization where all these blue cells are the positive. The probe was specifically for JC virus, and you have to make a diagnosis of JC virus nephropathy. So this is it. This is the thing that you need to remember. You should suspect it when IHC is positive, but there is absence of virus in the blood and in the urine. Morphologically, you cannot differentiate it, and you need to do the in situ hybridization to differentiate it. Moving on to the case, second case. This is a 58-year-old male whose native kidney disease was FSGS, who received a live donor renal transplantation on regular immunosuppressants. He was doing very well. However, at 3 months, he landed up in the hospital with a creatinine of 2.6 with proteinuria, and a biopsy was done. This was something that really surprised us because the glomerulus is showing necrosis. It was a necrotizing glomerular nephritis here. You can see the fibrin here. The glomerular architecture is completely destroyed, and a dense inflammation, predominantly plasma cells, a lot of plasma cells in the interstitium, occasional neutrophils, occasional eosinophils and lymphocytes, but predominantly plasma cells. Whenever there's a plasma cell, always consider the possibility of a virus or any fungal infection. So this is the trichrome to show the fibrin is staining very beautifully, a fibrinoid necrosis. And one glomerulus on a silver stain, we picked up an area of collapse. So this is not a crescent, this is a collapse because there's mesangiolisis, and these cells are the visceral epithelial cells showing those very characteristic protein resorption droplets. So there was necrotizing glomerulonephritis and there was collapsing glomerulonephritis. And what does the interstitium show? Dense inflammatory infiltrate in the surrounding interstitium. We saw that lot of inflammation, and then one of these tubules had this very enlarged cell with an intranuclear inclusion and cytoplasmic granular inclusions. The surrounding tubules also showed tubulitis. You can see this on an H&E itself. You can make out there is tubulitis. So with this characteristic picture, we always do a IHC for CMV, and we've had a case where there was a combined CMV and BKV. So we, by routine, always do a SV40 also, but SV40 was negative. Cytomegalovirus IHC was positive on these cells, and a diagnosis of cytomegalovirus nephropathy was made. IF, we were very worried about what is happening in the glomerular part. The IF was negative, ANCA anti-GBM serology was negative. So we concluded it was a cytomegalovirus-induced collapsing glomerulopathy and necrotizing glomerulonephritis. So CMV is known to cause a variety of end organ diseases. This is unlike BKV, which is usually restricted to the kidney or the ureter and the bladder, whereas CMV, you can have a lung infection, a colitis, esophagitis, hepatitis, gastritis, or a nephritis, or you can have multiple organs being involved at the same time. When BKV was infecting only the tubular epithelial cell, here CMV, in addition to the tubular epithelial cell, it can involve the endothelial cells also. So this is a CMV within the endothelial cell of the glomerulus. It can be the endothelial cell of the peritubular capillaries or the arterioles also. So it's not just a tubular epithelial cell, it's the endothelial cell also. Characteristically, the cell is enlarged. That's how the virus gets its name. And it usually has an inclusion with a surrounding halo. So this is resembling the eye of an owl, a dark area and a paler area. So that's why it's called an owl eye. You need not always see it because the cell is so big. It depends on what level it's sectioned at. So you may not always see this, but if you see it is like very easy a diagnosis, though we always do an IHC to confirm it. And in addition, like BKV had only intranuclear inclusions, whereas CMV, you also see cytoplasmic inclusions. The previous one was, you can see, very nice cytoplasmic inclusions. There is variable interstitial inflammation. Co-infection with other viruses or fungus are known to occur. And also, this is a virus which also causes glomerular lesions. It can cause an endocapillary hypercellularity. It can cause collapse of the glomerulus, or it can cause necrosis of the glomerulus also. IHC is done to confirm it. EM is very characteristic because it has a central core and a thick capsule around it, though, and the inclusions are seen both in the nucleus and the cytoplasm. So these are just case reports of CMV causing necrotizing crescentic GN in the transplant, CMV causing a collapsing GN, and this is our patient which had both necrosis and collapse in the patient. So we tend to, we had this biopsy, the plasma cells gave us a clue that there is something more to it. Otherwise, with that amount of glomerular necrosis and collapse, we would have attributed the graft dysfunction to be because of, post-immune and or some other cause of glomerular pathology, completely overlooking the possibility that it is a cytomegaloviral infection. So thorough evaluation of all the compartments is very important in a transplant pathology. The third case I've been asked to, the virus I've been asked to talk about is a herpes simplex virus. I have never come across, I've never diagnosed a case of herpes simplex virus. It's extremely rare. Even while preparing this presentation, I was searching the literature. There are just 4 or 5 case reports. And here we have a case from Delhi, from Dr. Rajan Dugal's team, which here, it was a herpes simplex type 2 nephritis, where the biopsy showed a lot of necrosis and the endothelial cell showed this enlarged cell with a smudgy nucleus, and immunohistochemistry for HSV2 was positive. So whenever there is, when you would probably start off doing a CMV is negative, BKV is negative, think of the possibility of a herpes simplex also causing these similar changes, and not just attributed to a regenerative changes, because there's a lot of necrosis and damage to the surrounding interstitium. So HSV, again, the incidence is around 53%. Just like CMV, it is not just restricted to the kidney. You can have multiple organs, from oral to genital mucocutaneous lesions to a number of organs having these HSV type of inflammation. And here that was Dr. Rajat's case, which was an HSV type 2. And this is an HSV type 1 virus causing nephritis. And this is a very nice article because they have discussed in detail what all should you consider when you have acute interstitial inflammation. See, in a graft, the moment we have a lot of interstitial inflammation, if it's predominantly neutrophilic, we tend to just think it's bacterial pyelonephritis, or if it's predominantly lymphocytic, we tend to call it as a rejection. But this is something that will, help us to remember there are a number of causes. All these viruses can cause an acute interstitial nephritis in the allograft kidney. So this is a very nice article. Probably you want to read further. This could be a good one to expand our knowledge. Moving on to the last case. This is a 37-year-old male whose end-stage renal disease was, again, chronic glomerulonephritis. We did not have a tissue diagnosis. He underwent a deceased donor renal transplantation with induction and triple immunosuppression. He was doing very well. 10th post-op day, his best creatinine was 1. He was discharged, went home happily, only to return back on day 23 with passing frank blood in the urine. There was no dysuria or no fever. And when he came back, he had a creatinine of 1.5. So the next day, his DJ stent was removed, and with the hope that, things would settle. However, his creatinine continued to rise. Hematuria persisted, and so a renal biopsy was done. So this is the picture here. A lot of inflammation. I did not focus on the glomerulus. They were unremarkable. A lot of interstitial edema here. A lot of neutrophilic infiltration. Tubular-centric inflammation predominantly. It's like very, very suggestive of pyelonephritis. So this was like a very spot. Okay, this acute pyelonephritis patient has no fever, probably because he's so immunosuppressed. That is why, but he's got frank blood in the urine. But if you look carefully, it is not just a simple pyelonephritis. These are cells with very smudged nuclei, the tubular epithelial cells showing smudged nuclei, a lot of necrotic and degenerated cells, a lot of inflammatory cells packing the tubule. the sloughed off cells, the cell debris is also taken up the positive. Those are virally infected cells causing a positive reaction. So a diagnosis of adenovirus nephropathy was made. This is one of the viruses that appear earlier in that 1 to 12 months period that we showed, the earlier time. In fact, this was within the first month, which is a very early presentation. They clinically resemble pyelonephritis with hemorrhagic cystitis, graft dysfunction. They can have graft tenderness and fever. So a clinical impression can be pyelonephritis, and it's very easy for the pathologist also to think in that lines because of the amount of interstitial edema. There is some interstitial hemorrhage, and this overwhelming neutrophilic necrotic karyorectic debris here to suggest to suggest pyelonephritis. But always, whenever you see a case of pyelonephritis, always rule out whether there's a possibility of an adenovirus causing it. So adenovirus, it is involving the tubular epithelial cells. As we saw, it is a tubulocentric inflammation. The inflammation is localized around the tubules with a lot of necrosis and hemorrhage. Around 75% of the biopsies can show ill-defined granulomas, not like the typical mycobacterium type of granuloma, but very ill-defined. This biopsy did not have that. These smudgy basophilic nuclear inclusions and this detached degenerated cell, this very characteristic appearance is the one that gives you the clue that it is an adenovirus. This is what the EM looks like, very similar to BKV or even a parvovirus. Now let's summarize all that we saw. There are a number of morphological features that can suggest viral infection. One, what do you look for in a biopsy? You look at the site. You should look at the tubular epithelial cell. You should also look at the endothelial cells of the peritubular capillaries and the arterioles. Do not miss looking at the glomerular endothelial cells and the parietal epithelial cells, because you can have viral infections anywhere here. A number of nuclear changes from very well-formed inclusions to some granularity to just enlarged nuclei with prominent nuclei. So the nuclear changes there's a whole spectrum of it. You cannot just rely on the typical inclusion. So you have to keep a wide possibility when you see these nuclear changes. The tubular adjacent changes could be tubular epithelial injury. They could be tubulitis, sloughing of the tubular epithelial cells. And in the interstitium, you could either have a mixed inflammation, or you can have predominantly mononuclear cells, or you can have a lot of plasma cells. And especially BKV is known to cause a lot of interstitial fibrosis. So there are a lot of changes. All of these can raise a flag that it could possibly be a viral infection. So you should have a high index of suspicion and do not hesitate to proceed with immunohistochemistry. So renal biopsy is the gold standard to diagnose tissue invasive viral infection in the allograft. Light microscopy, they have characteristic diagnostic features. However, immunohistochemistry is much more sensitive and specific than identifying it just by light microscopy, and we should definitely do that. And finally, to conclude, why is it important? We already talked about it in the beginning. These viral infections are known to cause acute or chronic rejection episodes through a number of ways. They can activate HLA class 1 antigen-specific T cells. They can directly damage endothelial cells. They can release pro-inflammatory cytokines, and all this can cause an increased expression of HLA class 2 molecules, and then you can have an episode of rejection. Though the list of viruses, oncogenic viruses in a graft from Epstein-Barr virus causing PTLD, I have just included these 4 viruses here because this was our topic. These are not usually in the list of oncogenic viruses, but you need to remember it's been proven that CMV has an oncomodulatory role, in the sense it can favor both the development and the spread of cancer cells. And there is a query whether CMV has a role in gastric carcinoma in allograft recipients. BKV is thought to promote growth and aggressiveness in the urothelial carcinoma of either the bladder or the ureter or the renal pelvis. HSV2 is associated with cervical cancer. As of now, adenovirus is not associated with any malignancy. And with that, I conclude today's class, and I sincerely thank all of you for your patient hearing and the organizers once again for this opportunity. Thank you.
Yes, thank you. Thank you, ma'am, for this wonderful class. We got enlightened by this visual treat of beautiful pictures, important information, and the references you have provided. Can we take up the questions, madam?
Sure, sure. Yeah, there are some questions there. Yeah, okay.
Yes. So, yeah, is there any particular reason why BKV is predominantly found in the medullary tissue and not much in the cortex?
Oh, no, no, no. You shouldn't be under the impression that it is not found much in the cortex. What I try to say is the earliest lesion is in the medulla. See, the picture I showed you is all in the cortex. So it's not like, the take-home message is not that. The take-home message is earliest lesion, it tends to be in the medulla. And why is it in the medulla is most likely it has a tropism for medullary tissue. Basically, yeah, I guess so, because we know that in a latent stage, it is usually in the urothelium. So you can have it in the bladder, in the ureter, or the renal pelvis. So the medulla being closest to the urothelium is likely, I'm just assuming, I really don't know, that's a wild guess. So that is why it is in the medulla, especially up from the corticomedullary junction to the deeper medulla. But once it is an advanced disease, very well, it will be all over the cortex also. So that's a little bit of a correction.
Yes.
Okay.
Thank you, ma'am. Is it possible to have BK virus nephropathy with BK viruria, but no viremia?
Viruria, but no viremia. Yes, I came across some papers, some case reports where, they have described very clearly that, in fact, they went ahead, they wanted to rule out whether it is JC virus, and they have proven by in situ hybridization that it is actually BK virus with viruria, but without viremia. Yeah, there are case reports. Why is it? I don't know.
Yes, ma'am. Yes, ma'am, any specific biopsy changes related to transplant patient with COVID-19 infection with graft dysfunction that we didn't include, if you can tell us?
Yeah, COVID-19. Actually, I see Dr. Swarnalatha madam here.
Yes.
So ma'am has done a very nice study, and we sort of did not publish it. We were supposed to do it. See, we took out all the biopsies, graft biopsies of transplant patients who had COVID. And we found, I mean, I don't remember the exact numbers, but rejection, definitely there was a higher incidence of rejection, both cell-mediated and antibody-mediated and combined rejection in them. There was more ATI, there were patients with ATI there. And we found TMA, that I remember we found a higher incidence of TMA among these patients. And also I found that pyelonephritis, for some reason, some of our patients, the number of pyelonephritis cases were much higher among those patients with COVID than the patients, the regular transplant patients without COVID. And I very distinctly remember there's a very patient who had a beautifully functioning kidney immediate post-transplant, and suddenly he had anuria, and the Doppler study showed no blood flow, and the biopsy showed cortical necrosis, and they did a graft nephrectomy. The renal artery was completely thrombosed, and this man had a severe COVID infection. So we've had the whole spectrum of from ATI up to cortical necrosis to graft loss, graft necrosis because of COVID.
Thank you, ma'am.
Yeah.
If BK viremia and viruria is not present, if biopsy features are suggestive of viral infection, do we need to send HSV, PCR, or JC or adenovirus? Of course, management will be the same, but the diagnostic purpose. Yes.
The biopsy features of viral infections are there. Normally, how I think each institute may have a different practice, but for us, I mean, the cost tissue we always consider. So we don't do the entire panel. First, we do BKV. Okay, BKV is negative. CMV, very unlikely, because morphology of CMV, you pick it up. But then if the clinician says to do CMV, we do that. Adenovirus also is all based on the light microscopy with a lot of inflammation. But if you've done BKV, CMV, adeno, and it is negative, you could always think of the possibility of a regenerative or a reactive change. because any tissue, any cell that is injured when it undergoes regeneration will show those nuclear features. There may be hyperchromasia, there's nuclear pleomorphism, there's prominent nucleoli. So all that, always a differential diagnosis for a virally infected cell is a cell that is undergoing repair. So probably Ki67, which is a cell proliferation marker, if you do that in a tissue which is repairing, you have a Ki67 index that is very high. And in that case, you can attribute it to the reactive process and not a viral process.
Yeah, if SV40 is negative, then we can
start off with all the virus. With everything is negative, then you consider.
Somebody asked, are we seeing more TMA in grafts in post-COVID era?
We did, but we never published it. Yes, we did see a lot of TMA.
Ma'am, like how early would you advise to do the SV40 staining, or it is a routine practice? Like how many days post-transplant?
Yeah, after 1 month, definitely. It is not a routine practice because I am not working in an institution. I get biopsies from different nephrologists. So each of them have their own protocol. Some nephrologists, irrespective, just ask for BKV and CMV. Some ask only for BKV. Some don't ask, and I have to suggest. So the practice among nephrologists I've noticed is not uniform. And ideally, given a chance, like my protocol here is, if there is absolutely no inflammation, there is no viral changes, then we don't do. But if there is like I1, T1, those borderline changes, every borderline rejection, every case, we have to do a SV40 to rule out, because BKV can produce those, those not enough to call it rejection. At the same time, there is inflammation. So that definitely we do the case. Then, of course, if there is a clinical indication.
Yes. Yeah, that's all. The questions are done.
Yeah.
Thank you. Thank you once again.
Oh, welcome. Thank you so much.
Thank you for taking up time. And I would like to thank Dr. Swarnalatha Madam also and the attendee. Thank you, ma'am. Good night.
Good night.
Thank you.